I thank the organizing committee for the kind invitation to speak about wide field technology. Is it coming to ages? In the past 2 years, I have collected experience in wide field imaging, which completely changed my way of managing patients and reaching diagnosis. Focusing on angio-OCT, you all know that the main advantages are to study the vascular network in a non-invasive, fast way and the ability to have information on the vascularization of different layers in normal situation and in abnormal situations. So we can apply the same advantages to the peripheral retina, leading to increased indications. This is the normal wide field angio-OCT of a patient. But the question is, to which extent does wide field angio-OCT allow to avoid fluorescein angiography and ICG? So to answer, we should also ask, what do we want to know from fluorescein angiography and ICG? We want to know about ischemia, leakage, and presence of abnormal vessels in the retina and in the choroid. So can we study ischemia with angio-OCT? In cases like this, we don't really need to go forward because it is pretty evident from the color picture that this is an ischemic case. A case like this is likely non-ischemic. Vision is 0.4. There are limited hemorrhages only in 3 quadrants. There is no relative afferent pupillary defect. And in fact, the wide field angio-OCT only confirmed the absence of ischemia. We used to struggle to know about ischemia using functional tests, morphological tests, and none of them were very specific. Today we have this new imaging technology. Studying this image, would you vote for ischemic or non-ischemic? Probably ischemic because there are hemorrhages in 4 quadrants, soft exudate, 2200 vision, and relative afferent pupillary defect. Infrared is of no help, nor autofluorescence, blue nor green. And the wide field angio-OCT comes as a surprise. There are no ischemic areas. The problem in this case is a CME, which can be solved with 1 injection of anti-VEGF, and in just 1 month you see the difference between pre and post injection. This is another case of a woman, 47 years of age. This is the healthy eye with normal angio-OCT, and this is the other eye with evidence of vascular occlusion. Is it ischemic or non-ischemic? We see ghost vessel in the temporal and nasal quadrants, so there might be ischemia. Based on the OCT, we don't really understand why vision is only 0.3 because the external retina in the macula looks fine. However, the angio-OCT shows the reason of the low vision. From the wide field B scan, we know the thinning on the temporal retina, but I think the most striking image is this one. This is the most informative, showing extreme ischemia in the peripheral quadrants. And this is the superimposed image of color and angio wide field, just to understand the latitude of the problem. This is another case, a male 55 years of age with CRVO and recurrent CME. Regularly, like a clock, the CME comes back 8 weeks after each injection, so we wonder about ischemia. From the angio-OCT, we don't see ischemia in the central retina, nor from the 23 mm angio-OCT. It is only the ultra-wide field angio-OCT that shows the temporal ischemia, and it is a guide for us to know how to proceed with pump photocoagulation. This is the color and in fast ultra-wide field showing the PRP in progress. In the same patient, we studied the OCT of the iris, so we learned that we can do angio-OCT of the iris, and we are studying more into this topic. This 92 years old woman came complaining of sudden loss of vision in the left eye, and I thought it was just her AMD. In the right eye, she had a normal retinal vascularization. Her vision was 2200 as usual. In the left eye, vision was hand motion. And I could see from the angio-OCT that there was no blood flow in the retina, so she had a central artery occlusion. Can we study leakage with angio-OCT? Again, this case is pretty obvious and we don't need further imaging to know what to do. But in this 45 years of age woman, I could not decide the management based on this color image only vision was 20/20, and the OCT was showing only mild CME. But the angio-OCT showed a neovessel and ischemic area, so I advised for injection and PRP. She came back 9 months later. She had partially lost to follow-up, and her vision had dropped. In only 9 months, she had an increase in ischemia, and the neovascularization had grown as an attempt of the eye to compensate for the ischemia. Leakage is helpful in differentiating neovascularization from shunts. This is a case of branch vein occlusion, and it would be great to be able to differentiate neovessels from shunts to know the management. If we combine wide field OCT with the B-scan, we have the answer, because the pre-retinal hemorrhages, pre-retinal blood flow will indicate the neovessels, while intraretinal problems in the B-scan will indicate shunts. So to the question, can we study leakage? Yes, indirectly we can. Is there a role of wide field imaging also in the study of the choroid? This is more challenging, and let's start with the choroidal transplant. The retinography tells me the retina is attached and the patch is well centered. The autofluorescence tells me the patch is healthy. Fluorescein angiography and ICG tell me the patch is vascularized and there is no recurrence of neovascularization. But then again, the angio-OCT give me the same information in the center and in the peripheral retina. This is another case in a highly myopic eye, and I'm showing you this case because although there is a deep staphyloma, have a very good segmentation, and the angio-OCT give me information on the vascularization of the patch, the atrophic areas on the nasal side of the papilla, and the harvesting site where I can see the vascularization of the retina on top of the sclera. So yes, in autologous transplant, I have all the information I need without fluorescein angiography and ICG. What about tumors? This is even more challenging. There is a whole list of things to know in the differential diagnosis of a choroidal lesion. However, focus on these images. She came asymptomatic 20/20 vision. When I see that lesion, I immediately take her to the wide field imaging, color picture, autofluorescence, SLO, B-scan. I see the subretinal fluid, angio, OCT, wide field. I see the difference in the vascularization. So yes, she underwent also ultrasound, fluorescein and ICG, but I knew from the wide field imaging that she had a choroidal melanoma. This is the image pre and post proton beam radiation. This is another case, a very similar lesion in the macula. The vision is 20/40. With wide field OCT, I see that there are no other lesions in the periphery. There are telangiectasias. With autofluorescence, I see the signs of nasal inferior retinal detachment with gravitational aspect. And the B-scan shows intraretinal fluid over the macula and over the lesion. The angio-OCT in the choroid shows dilated large choroidal vessels, confirmed with the NFAS. That shows also the distribution of the intraretinal fluid. The diagnosis was a benign choroidal angioma treated with PDT, and you see here the pre and post PDT treatment. And this is just a series of different choroidal lesions to show you that with the wide field non-invasive technology, we might reach a good level of suspect in the diagnosis. At the moment, multimodal imaging is still necessary to reach precise diagnosis in choroidal lesion, but I think further improvement in the wide field technology might lead to a less invasive way to diagnose this patient and manage the case. I leave you with this beautiful image of a wide field choroidal angio-CT showing the vortex vein flow. Thank you for your attention.